Please now welcome Dr. Tanya Siddiqi, Director, Chronic Lymphocytic Leukemia Program and Associate Clinical Professor, Department of Hematology and Hemopoietic Stem Cell Transplant at City of Hope National Comprehensive Cancer Center and a member of the CLL Society's Medical Advisory Board. Dr. Siddiqi.
Hi, everyone. Thank you for this invitation to speak for the CLL Society here today. It's always an honor. So I'm going to talk about CAR T-cell therapy in CLL, and it's obviously a very exciting up-and-coming field of treatment, not just in CLL, but in all lymphomas, and even some leukemias, actually. And so, as you all very well aware, that CLL is a form of incurable, low-grade, slow-growing B-cell lymphoma, and we know that patients, can do very well with novel therapies that we have these days, targeted therapies, newer combinations, even fixed duration therapy instead of sort of prolonged duration therapy. And we know that people who have some of the poorest features of the CLL, like 17p deletion, unmutated IGHV, complex cytogenetics, et cetera, those are the ones who may actually potentially relapse or progress sooner on even the novel therapies, and ultimately sort of need newer and newer drugs sooner and sooner, rather than people who have good risk features of disease. But inevitably, in a disease like CLL, which is incurable, uh, but long durationed, we end up following patients for a long time and having to change treatments over time as well. And therefore, there's always a need for newer and better treatments in this field. One of the things that excites me most about CLL treatment nowadays, and where CAR T cells sort of fit in, is that given the incurability of the disease, we want to try to see, is there anything we can do short of allogeneic stem cell transplant or bone marrow transplant from somebody else, which can lead to a potential cure or very long-term remission in patients, with obviously controllable or minimal sort of toxicities. And one of the things that can potentially answer the bill, or at least we're investigating to see if it can answer the bill, is CAR T cell therapy. So before I go on to talk about data, and I present my data to patients as well and caregivers in a very scientific way, much like I do for scientific presentations and meetings, because there are a lot of you who are very well versed in CLL data analysis, so to speak, whereas some of you don't know all the lingo as well. And so I'll try to break it down and use more layman's terms as I explain wordings, but my slides might look a little bit scientific, and I apologize for that if you don't understand it, but just try to follow what I'm telling you in my words. So whenever we have patients with CLL, we know that the CLL is coming out of, or the cancer is coming out of B cells or B lymphocytes in patients' bodies, and there are a separate set of lymphocytes called T lymphocytes, which is where we make the CAR T cells from. So we take patients' own T lymphocytes, we manufacture them into CAR T cells in the lab, and then we give a little bit of chemo and then give back those CAR T cells to patients and see how they do over the next month, and then of course several months and years subsequently. And one of the most exciting data that I heard about very recently, within the last couple of years, was that out of the first 3 described University of Pennsylvania CLL patients who had received their University of Pennsylvania CAR T cells back in 2010 or 2011, I think it was, 2 of those patients in 2019 were still in remission without any detectable CLL. Even minimal residual disease was not detectable, and with detectable CAR T cells in their system still. And that, to have such long durability of CAR T cells lingering in the body, is not very common actually for CAR T cell therapy, but it's a very good sign that, of course, these patients have now gone, 8-9 years without relapsing. And maybe the CAR T cells in the system are helping keep them in remission after they had already failed 4 or 5 or more median sort of lines of therapy, including, I think, 1 or 2 of them had allogeneic stem cell transplant in the past as well. So this was very sort of encouraging to the CAR T world, that yes, potentially patients can have long-term remission. And based on that early data of those 3 patients back in 2010 or 2011, University of Pennsylvania then went on to report on a total of 14 patients who had had a median of 5 prior lines of therapy, ranging from just 1 line of therapy before to 11 prior treatments. So median would be sort of half better, half worse, sort of a thing. And they saw that with their CAR T cells, there was about a 57% overall response rate, which means that some patients went into a complete remission, some patients went into a partial remission, but the total of these was about 57% of all these 14 patients. And whenever we give CAR T cells, the first thing that can happen in the body in the first couple of weeks is that those T cells, CAR T cells, go in and start fighting the B cells and produce this hyperinflammation response, which is called cytokine release syndrome. So that's a pretty common side effect. It's expected. Some people can have breakdown of their tumor cells and their white cells and lymphocytes, so that as the CLL shrinks, they can have some tumor lysis syndrome potentially, and that's managed by allopurinol to protect the kidneys and some IV fluids, etc. And then because these CAR T cells, the way they work, they target B lymphocytes to kill the CLL cells. They also sometimes, in fact, often kill a bunch of the healthy B cells that are in the vicinity, and therefore end up having low immunoglobulin levels, requiring IVIG periodically and things like that for many, many months, even years sometimes afterwards. It's not everybody, but a lot of patients will. And so these were expected sort of side effects that University of Pennsylvania reported, and manageable, essentially. And in the patients who achieved complete remission, there were 4 out of the 14. They were able to, state that there was no detectable minimal residual disease, which is a special test that tries to detect very, very small specks of CLL in the blood by very special testing. And that's our human ability to measure the smallest amount of CLL in the blood. If you don't detect it, meaning MRD undetectable, doesn't mean the cancer is cured necessarily. I hope it does, but it doesn't necessarily mean that. It's just that our human ability to detect any lower than that may not be available yet. And so, sort of in conjunction with what University of Pennsylvania was doing, a few years later, we started seeing data coming out of the Seattle group, Fred Hutchinson Cancer Center group. And they had a trial with a product called JCAR14, which splits the T cells into CD4 and CD8 positive T cells, which are normal types of T cells in our bodies, but University of Pennsylvania was giving them all in one bag, whereas Seattle was splitting them and then making them into CAR T cells and then giving those to patients in a one-to-one fashion in equal amounts, so that you know how much you're giving to patients and things like that. So they tested their product in about 24 patients with relapsed refractory CLL who had already progressed on ibrutinib, and 6 patients had already also progressed on venetoclax. And what they found was that there were, a bunch of patients who had the expected cytokine release syndrome hyperinflammation response. Sometimes they can also be this quirky side effect of neurotoxicity. So, just confusion, headache, or just totally altered mental state for a while until steroids are given to kind of fix that. And they found that one person may have actually died from one of these side effects, but overall, 71% patients responded to this particular treatment, which was very encouraging. And what they found was that 88% patients who had CLL in their bone marrows at baseline were undetectable by MRD testing. And those were the ones that really did not progress over a 2-year follow-up period, although initial follow-up that they reported at was pretty short at 6.5 months. So you see the blue line up there in both of these graphs that shows progression-free survival on the left and overall survival on the right. And it seems that patients who developed undetectable minimal residual disease with these CAR T cells were the ones who actually did not respond with their CLL for a long time. It's still only a couple years, which in CLL terms is fairly short. Remember, you have to go more than 10 years without relapse to kind of start talking about possible cure or, permanent remission, I guess. But 2 years is a short period of time. Nevertheless, we'll see how this evolves over time. But the second thing that the Seattle group did was to take their JCAR14 product and see that if you don't stop ibrutinib, let's say somebody is already progressing on ibrutinib, so instead of stopping ibrutinib at the time you start um, the treatment with JCAR14, let them continue the ibrutinib so that patients were on ibrutinib at the time their T cells were collected, a process called leukapheresis. When the T cells were collected, they had already ibrutinib sort of exposed T cells in the mix. Those T cells were then manufactured into CAR T cells. Patients stayed on ibrutinib through this whole time. The process takes about 3 or 4 weeks typically, and then everybody gets sort of fludarabine and cyclophosphamide for 3 days, which is something called lymphodepletion. You need that chemo to make space in the body for these CAR T cells to go in and be able to multiply, divide, and grow in number and do their job. And so after 3 days of fludarabine and cyclophosphamide is when patients actually get the infusion of these CD4 and CD8 CAR T cells. And the patients remained on ibrutinib through this whole time. After CAR T cells, they remained on ibrutinib for up to 90 days at least. And the goal of ibrutinib was to see whether the T lymphocytes collected in the bag of leukapheresis were better. The CAR T cells produced and given back to patients functioned better. Patients may have less hyperinflammation with ibrutinib in the system, and less something called tumor flare would be less as well if ibrutinib was in the system, because ibrutinib can calm down inflammation a little bit. And so they found that patients tolerated the combination of their JCAR14 with ibrutinib pretty well. 13 patients, or 68%, were able to stay on ibrutinib the whole time as planned. One patient did have some kind of a irregular heartbeat issue, they think, and actually passed away, which was fairly severe. And we know that ibrutinib can cause atrial fibrillation, irregular heartbeat. Maybe if the patient was older, I don't know if they didn't tolerate the ibrutinib very well, or something happened where they had a death. But for the most part, at the end of the 1 month of following patients after CAR T cells, the overall response rate was 83%, and 61% were MRD undetectable. And at 1 year, overall survival and progression-free survival were 86 and 59% respectively, although 1 year, again, is a very short period of time in CLL terms to see what the outcomes were with treatment. So these patients obviously hopefully are being followed over time, and we'll get to know other results down the line. But bottom line, this early study showed that their JCAR14 and ibrutinib combination did lead to lesser cytokine release syndrome severity, lesser cytokines or chemicals released during cytokine release syndrome that can then cause more side effects, even though the CAR T cells worked as well or expanded in numbers as well as when ibrutinib had not been in the system as well. And so this is just the overall sort of summary of their Seattle CAR T cells with or without ibrutinib. But I'll jump on ahead to the next phase, which is a commercialization of this JCAR14 product, if you will, something that's been taken up by Juno Therapeutics and then subsequently Celgene and now BMS, which is a company that owns Juno, et cetera, now, that they then formulated a product called JCAR17, which is again the CD4 and CD8 CAR positive T cells given in a 1-to-1 fashion with something called a 4-1BB co-stimulatory domain. But it's just produced in a manner that is that they've been able to sort of ramp up and make in a much larger numbers for more and more patients, and that's the commercialization part of it. So the product isn't exactly similar to what Seattle did, but it's just sort of came out of there. And I was lucky enough to present the results of this phase 1 part of the trial called Transcend CLL 004 study, which was for patients with high risk prior ibrutinib treatment, relapsed refractory CLL patients, where everybody got lymphodepletion with fludarabine and cyclophosphamide before getting their lysocell or lysocaptogene maraleucel or JCAR17 product infused. There were 23 patients in the phase 1 portion. And now actually the phase 2 portion has just been completed. Actually, the accrual is just completed. There's a separate cohort of lysocell or JCAR17 with ibrutinib, as can be expected. And so that combination is still ongoing. Phase 2 expansion of enrollment. There's slots for that if patients are eligible. We'd be happy to see more patients for that. But essentially, everybody had to have failed prior BTK inhibitor therapy. In these 23 phase 1 patients, it was all ibrutinib. And they needed to have failed a total of 2 or 3 different lines of therapy, depending on whether or not they had high-risk features of their disease or not. And you can see in the middle column that median age was about 66 years. Majority of patients had advanced stage disease. 83% had high-risk features like deletion 17, et cetera. Median sort of number of lines of therapy was 4. All of them had had prior ibrutinib. And actually, there was a subgroup of 11 patients out of the 23 who had failed not just prior ibrutinib, but also prior venetoclax. And you can see in this chart, I'm going to point to the grade 3 CRS. Grade 3 CRS row, which shows that only 2 people had grade 3, or it's out of a scale of 1 to 4, grade 4 being the worst, grade 1 being the least. Grade 3 is sort of somewhere getting up there where people have more than just fever and chills as a manifestation of cytokine release syndrome. It's also low blood pressure, maybe requiring oxygen, things like that. So grade 3 was only in 2 patients. There was no grade 4 or 5 toxicity of cytokine release syndrome. And the confusion part, the neurotoxicity, was only in 5 patients with grade 3, or actually 4 patients with grade 3 and 1 patient with grade 4 neurotoxicity. So reasonably very well tolerated and easily managed with products like tocilizumab, steroids. We're very well versed in how to use all of these now in the hospital, and we try to get the patients through the first 2-3 week period, which is when these side effects can happen. And then we reassess for disease at 1 month. And you can see in this graph that each of these rows, the blue lines, et cetera, it depicts each individual patient out of the 22 who we could evaluate for response. The first sort of column of bubbles is the time point at 1 month where they all underwent assessment for the first time. And 82% patients had an overall response rate of CR or PR, with 68% achieving this response at the very first time point of 1 month. And you can see over time, as far out as now 24 months, we followed a number of patients and they're remaining in remission, with the dark blue lines being partial remission, these turquoise lines being complete remission. And more importantly, it seems the black circles being undetectable minimal residual disease, as well as the hashed lines, whether in blood or marrow, is different. So very encouraging, the median duration of response, which is when half of the patients have remained in response, has not been reached. So it's above that, meaning that half of the patients are still in, more than half the patients are still remaining in a response. And then the median progression-free survival in the total set of patients, which is the green line, is 18 months, which means after 18 months is when more than 50% patients start relapsing or progressing. But if you look at patients, and we don't have the picture for this because we're going to do it when we have more patients in the mix, but if you look at patients who had achieved undetectable minimal residual disease with CAR T cells, then those patients have still not progressed for longer. The ones who did not progress for even longer. And then the ones who did progress, majority of them, and there were only a handful of them, but majority of them unfortunately progressed with Richter's transformation, which is something we're still trying to understand and deal with, because clearly the CLL was very well managed by CAR T cells. So in summary, the lysocell treatment or JCAR17 treatment led to very rapid, deep, and durable responses. We followed these patients for up to 24 months. We've had now patients on the monotherapy arm completed both phase 1 and phase 2 portions. We will read out the phase 2 results hopefully some months later or next year for sure. But in the meantime, I wanted to show you a little bit about how the patients who got combined ibrutinib plus lysocell are also doing. In the early data in 19 patients, you can see that there are a lot of people who are still being followed and responding. Only one Richter's transformation patient and 89% maintained or improved upon their response from day 30 up to the 6-month follow-up as well. So very encouraging, very promising. There are a lot of investigations currently ongoing involving CAR T cells as well as bispecific antibodies in CLL. And so it's all very exciting. There's also work going on in allogeneic CAR T cells. So you don't have to wait for the production of CAR T cells from each individual patient, but rather you have something already sitting on the shelf from healthy donors that you can use. And hopefully, if that pans out, we hope that patients will definitely benefit from that in the future as well. And with that, I thank you for your attention. Let me introduce the next speaker, who is Patty Kaufman. She is the co-founder and director of communications for the CLL Society. Thank you.